Right, good afternoon, everybody. So, that's a very grand introduction, really, wasn't it? So, as Tiffany said, my name is Dr Anna Lawrence. I'm a urologist, trained in New Zealand, and I went abroad to get subspecialty training in Neuro-Urology and reconstruction. So I'd like to thank you all for coming and listening to me today. I like to keep things quite interactive, so if you have a burning question at any stage, please feel free to put your hand up. I have got a little gap halfway through. 4 questions, and I will loiter at the end if you want to come and ask me individually, if you don't want to talk about your plumbing in front of everybody else. However, with regards to plumbing, feel free to talk about it. That's all I do every day at work, is talk about plumbing, and I refer to myself as a plumber, with a lot of student debt at the end of it. So, without further ado, a lot of people will probably be thinking, why on earth would a urologist be involved in a Parkinson's Day presentation? When people think of urology, they think of prostate cancer, and then obviously they conjure up images, something similar to this. It's a fair question, but I can assure you we do treat more than just prostate cancer, and we do treat more than just male patients. We also see female patients and children. So in terms of what other things we treat, other than prostate cancer, some of us in New Zealand are trained in Neuro-Urology, which goes hand in hand with Parkinson's disease. So a neuro-urologist is someone who has subspecialty training in the investigation, treatment and management of any neurological cause of a urological dysfunction. So anything that goes wrong with your plumbing that might be related to a neurological disease process such as Parkinson's, but not limited to Parkinson's. So also people who have multiple sclerosis, spinal cord injuries, spina bifida, and people who've had a stroke. So obviously I'm here today to talk about how Parkinson's disease relates to this. So with that in mind, we'll talk about your plumbing and your Parkinson's disease. So when we think of Parkinson's disease, we know it's a neurodegenerative disorder of the substantia nigra and the brainstem, which is all just medical jargon for saying that that part of the brainstem no longer produces enough neurotransmitter to tell your body to move in the fluid way that it does when you're young. So commonly we think of this, and we have this, I've got this picture of this gentleman here, and classically this is what we think when we think of Parkinson's. So the stooped posture, the shuffly gait, the tremor, the face that doesn't move a lot. And these are quite well recognised symptoms of Parkinson's, both in the community and also in the medical community. Not so commonly recognised as a conglomerate of symptoms which are described as the non-motor symptoms. These are broken into sensory, cognitive and autonomic dysfunction. All right? So autonomic dysfunction includes the urinary dysfunction, which is where I become involved. So what is the autonomic nervous system? Well, the autonomic nervous system is what controls the automatic systems that in your body. So as you sit there listening to me, you're not thinking about your heart rate or your blood pressure. The automatic nervous system, or the autonomic nervous system, is just clicking that over and keeping it going. Now with Parkinson's disease, this is affected and it causes dysfunction of all of these things that you can see here, particularly urinary dysfunction, which is where I'm involved, and other neuro-urologists are also involved. In addition to that, also urology do see sexual dysfunction, which is related to Parkinson's disease, but I haven't touched on that today. So if your Parkinson's disease does cause your urinary dysfunction, what sort of symptoms may you start experiencing? Well, you might have what we call urgency. So urgency is when you get that urge to go to the toilet and you just have to rush to the toilet. Come hell or high water, you've got to get there. You get to the point where you know all the toilets are in every location that you go to. Up to 35% of people who have urinary dysfunction related to their Parkinson's disease will have this particular symptom. You can feel like you have to go to the toilet all the time. You've just been to the toilet, you know you've emptied your bladder, you've only just got back to the lounge at home and you've got to go again. We call this frequency, and it's not associated with a bladder infection, so you have a nice clean urine at the time, but you have to pee all the time. It's the sort of symptom that your friends notice because you're constantly interrupting conversations with them because you have to go to the toilet. And so about 32% of people who have urinary dysfunction related to their Parkinson's disease will complain of this complaint. There's also urinary incontinence, which is medical jargon is the loss of urine unintentionally at an inappropriate time. So that's when you wet yourself. Other urinary symptoms that can be experienced that are related to Parkinson's disease is progressive weakness of your stream. So for the gentleman, instead of being able to get it over the fence and put out a fire, you're now dribbling on your toes. So that can be related to your Parkinson's disease. Or you may get into the very painful and uncomfortable position where you actually can't go to the toilet at all, and you end up looking like you've got a 3-month baby because your bladder's so full. In addition to that, some people have the problem where they are up all night and they are peeing all night long. So 27 to 40% of Parkinson's disease patients will suffer from urinary dysfunction, and this number gets to the higher the further your disease develops, unfortunately. Male and female patients are affected equally, and that's quite important because often female patients are told that it's all part and parcel of getting a little bit older, that this is what your bladder does. What we know is that initially, say 10, 15 years ago, we did think that up to 80% of patients suffered from urinary dysfunction. However, more recent studies with a better understanding of Parkinson's disease, we can see that the number is slightly smaller, which is quite good news. We've also, with research, demonstrated that as your disease develops, unfortunately, the plumbing does get worse. And there is some recent research that suggests that your plumbing or your urinary dysfunction will be a prodrome symptom to Parkinson's disease, which means that you start getting some urinary problems before the Parkinson's, so before the rigidity, the tremor, the face changes kicks in. So why are these symptoms not talked about very much? Why are they not managed? Well, in a recent research project, they showed that up to 60% of patients who had Parkinson's disease were completely unaware that their urinary problems or their plumbing problems were related to their Parkinson's disease. They were also, for those who had spoken to their doctors, about 50% of them had been told by their family doctors that it was all just part and parcel of getting older. So the first thing, if I can make a very strong point today, if you've got urinary problems, your plumbing's not working, I wouldn't accept the comment that it's a normal part of ageing, because it is not a normal part of ageing. It is an abnormal thing that happens to some of us as we age, and when you have Parkinson's disease, it's most likely related to autonomic dysfunction with your Parkinson's disease. The other thing about urinary dysfunction or plumbing problems is it does decrease your quality of life. There is nothing worse than knowing that you're going to leak when you're trying to go out. A lot of patients I've met are housebound because they're so wet or because they can't go anywhere new because they don't know where the toilet is. So in terms of benefits of treatment, the quality of life that can be improved by treating urinary dysfunction it's great. No one wants to be housebound by their plumbing. So how do we work out whether or not these urinary problems are related to your Parkinson's disease and they're not another process? Well, it's really important that the correct investigations are done in the first instance. And the reason for this is because if there's something more simple going on, often like a bladder infection, this is much easier to treat and manage and may be completely reversible for you. Most of the investigations can be started by your family doctor, such as a simple urine sample for infection. However, often with our Parkinson's disease patients, they need more complex investigations, and that is an investigation called urodynamics. Urodynamics is an investigation where we look at how your bladder is functioning. It's what we call a functional study. It tells us how your bladder is holding urine or not holding urine anymore. It tells us how it's emptying urine or not emptying urine, as the case may be. And this is a study that's done by urologists in the hospital. As I say to most of my patients, I get a whole bunch of squiggly lines, which really doesn't look much like anything, but it gives us a lot of information about what we can and can't do. And this one here is a patient who's having what we call overactivity of their bladder, and they're leaking throughout the study. In terms of management of urinary dysfunction or your plumbing problems, it's really important that the treatments are aimed at improving, maximising the quality of life without causing any more morbidity. The reason for this is, as with Parkinson's disease is progressive, unfortunately the urinary problems that are associated with it are progressive as well. So it's all about managing them and treating them and making them not a predominant part of your life, not something that keeps you at home or stops you from interacting or being sociable with people. And one of the other key considerations is that once you start your treatment for your bladder, as age kicks in and we get a little bit older and Parkinson's kicks in a bit more, your bladder management may also need to be changed over this time. So it's often a fluid management program. It's never rigid in its approach. With our Parkinson's disease patients, there are unique considerations. Obviously, the mobility and the tremor and some of the cognitive decline that kicks in means that some of the things that we suggest for people who can get up and rush to the toilet is no longer appropriate. And so these things really need to be put into the mix in how you manage this. And this may be as simple as looking at a commode next to the bed instead of expecting someone to get up in the middle of the night and make it down the hallway to the bathroom. In addition, Parkinson's disease is a disease of the older generation, and so even though I said before it's not a normal part of ageing to have urinary problems or plumbing dysfunction, as we age we get other problems associated with the urinary tract that may be playing in with Parkinson's disease. So you may have more than two pathologies going on, so two things at once. And so that's why it's important to remember not only do you have Parkinson's disease, but we have age and we have to look at all things that could possibly be going wrong, because often, as I said before, it may be just a simple bladder infection. It's much easier to treat and you can recover and do well from that. Questions? No. Clear as mud? Oh no, there's one. So the urodynamics test, how long does the test take? So the test itself is done as an outpatient procedure. It should be done with no bladder infections, and the test can take probably about half an hour to maybe 3/4 an hour at the most. It shouldn't take much longer than that. Yes.
What's the treatment for it?
The treatment for
the
all of these symptoms?
Yeah.
I'm about to go through all of them.
Okay.
I work both. I'm based at Manukau Super Clinic in South Auckland, and I do time at Auckland Hospital as well, and I also work privately. So other than the North Shore, I cover the rest of Auckland. Okay. Any other questions? No? Okay, I'll carry on. So heading on to the management. So this gets a little complicated, so please feel free to interrupt me as we go. So detrusor overactivity, how I'm going to do this is I'm going to go through the symptoms and tell you how we can manage them, because that's the easiest way to go through them. So detrusor overactivity is when your bladder contracts and gives you the symptoms of urgency and frequency, or what we call the urge incontinence. So that's the bladder that may only have a very small amount in it, but it makes you go to the toilet all the time. You feel like you're rushing to the toilet when you get the urge to go, and as you go to the toilet you may leak all of your urine. You may also leak at night in bed, or you may find that you're having to get up all night long to pee as well. So as you can see here, these are the symptoms that we get with detrusor overactivity. Detrusor overactivity is not unique to the Parkinson's disease patients. People who don't have any neurological disorders can experience it as well, and those with multiple sclerosis, spina bifida, and so on also experience it. So we have quite a long history of research and management programs to deal with it. So whenever we treat detrusor overactivity in any patient group, we start with our conservative therapies, because these are the therapies that we can introduce that have no side effects for you. And so the first thing we always introduce is dietary change. It has been shown that caffeinated drinks, carbonated drinks, alcohol will increase your frequency, they increase your urgency, they increase the number of times you end up wetting your pants or get up at night. So simply decreasing these from your diet or eliminating them from your diet should have a good result in terms of urgency, frequency and leaking. It may not cure them, but some research in non-neurological patients has shown that up to 30% of patients who have the overactivity of their bladder, if they undertake the conservative measures, will not need to progress through and take medications or have surgery. So because there's no side effects, I always encourage people to give this a go. Some of the other things we can do is equipment changes. It's very difficult to ask someone who's slowing down in their mobility, as I said before, to mobilise 100 metres to get to the toilet in the middle of the night. So often just getting a simple commode or a urinary bottle for the gentleman next to the bed can sometimes help with nighttime incontinence. And these are all management treatment plans. None of them are cures, though. In terms of the conservative therapies, bladder retraining. So a lot of people read about Kegel exercises. Bladder retraining is slightly different to a Kegel exercise. Kegel exercise is what they tell you, and the ladies probably would have heard this when they were pregnant, to squeeze their pelvic floors, keep everything going. But bladder retraining is done with a qualified physiotherapist with what we call biofeedback, and the idea is to learn how your whole pelvic floor works. So then when you get the urge to go to the toilet, you're able to contract your muscles and delay, so you don't have to rush to the toilet. It decreases your incontinence episodes and allows, with time, your bladder to be able to hold more, so you don't have to go quite as frequently. Another, what we call conservative therapy, is for people who don't empty their bladders at all, or they only empty a little bit off each time. We do recommend that they empty their bladder at a regular interval. If the conservative therapies fail, we move on to medications. Anticholinergics are the first-line medication for TRUSA overactivity or overactivity of your bladder, and the first-line medication that we use in New Zealand is ditropan or oxybutynin, and that's been around since the early 70s. The problem with anticholinergics is they can increase some of the other autonomic dysfunction symptoms that Parkinson's disease patients experience. So they can increase cognitive decline, so they can make you more confused and muddled. They can make some people hallucinate, and they can increase constipation, and they do cause quite a severe dry mouth. So obviously these medications are not without their own risks. The idea behind them, though, when they work, they do work well, is decrease those episodes of going to the toilet, decrease the episodes of urgency, decrease the episodes of incontinence. So these are the ones we have available in New Zealand. On the left-hand side for you, is the generic name, and then on the right-hand side is the brand name as they're offered in New Zealand. So oxybutynin or ditropan has been around since the 70s. It initially was designed for people who had too much saliva. So it has the strongest side effect of giving you a dry mouth. The effect that it has on the bladder to decrease the number of times you go to the toilet or take away the urgency was just noted as a simple side effect for the patients that were being given it for another reason. It is an old drug, but it's a very good drug, but it does have the dreadful side effect of the dry mouth. Solonefacid and tolterodine are newer drugs that are designed particularly for the bladder, and tolterodine has a stronger and longer history with Parkinson's disease patients and neurological diseased bladders, and so it has a better outcome. In terms of how to get these funded in New Zealand, if you need to take the anticholinergics, the government will pay for oxybutynin off-pat. Your general practitioner can prescribe that for you. If the oxybutynin isn't enough and you need one of the other two, then Pharmac will supply it through a special authority funding, so that's something as a urologist we have to do for you. So if an anticholinergic fails, where to next? Botox. So Botox is the same drug that you see they put into the Hollywood starlets' faces so they don't move. It is actually a great drug for the bladder. So we've been using it in New Zealand and in Australia for the bladder for longer than the Americans have. We've been using it for over 15 years now in the bladder. What it does is it decreases the urgency again, decreases your frequency, decreases the episodes of incontinence, and it can increase your bladder capacity. How it's performed as a day case surgical procedure. So you come in, we put a little camera into your bladder, and then we infiltrate the bladder with little injections full of the Botox. I can see someone pulling their face here. It's done under an anaesthetic, so you won't feel it. and it takes about 20 minutes to do. The Botox then kicks in its effect about 7 to 10 days later, so it takes a little bit of time before it starts to work, and it lasts anywhere between 6 and 12 months, depending on everyone's bladders. The problem with Botox is, of course, it only lasts for 6 to 12 months, and so you have to have it repeatedly placed. The way most patients find it works best for them is when the symptoms start to reoccur, they ring up their doctor and say, I need some more Botox, and they get booked for it again. But it does work quite nicely. With the advent of Botox in the bladder, a lot of the other traditional surgical procedures that we used to perform for overactivity of the bladder have gone by the way. This next section is about what we call neuromodulation. I'm not sure if many people have heard of neuromodulation previously. It works under the same premise of a deep brain stimulator. Has anyone heard of those that they're placed for Parkinson's disease? So neuromodulation, there's two types of neuromodulation for urinary dysfunction. So this is the peripheral tibial nerve stimulator. What it is a little acupuncture needle that's placed by your ankle there, you can see in the picture, and then a little pad that's placed on the sole. It then sends little electrical pulses or shocks up through the nerve root, through the nerve that hits the ankle, that also goes to the nerve root in your sacrum, which is the back here, which is where the nerves to the bladder are. So the idea is it modulates the nerve from the ankle, goes back to the sacrum, and it changes the way the nerves feed down to your bladder. With peripheral tibial nerve stimulation, you have what we call an induction therapy to see if it's effective for you. It's once a week for 30 minutes and for 6 weeks. You start out by writing down your episodes of incontinence and urgency and frequency, and then after 6 weeks we get you to do it again to see if it's been of benefit. Most patients that I've used it on find it to be it's not painful per se, it's more just a hassle because you have to sit with your foot in a certain angle for half an hour. But it has been proven to be very effective, which is good news. So the results from quite a few research projects that have come out now across the world is that people do have decreased urgency, decreased nighttime voiding, which is one of the most difficult symptoms for us to get on top of. And the benefit of this, as opposed to some of the things that we do, there's no real side effects other than the time that you lose because you have to come in and have it done in the doctor's office. Yes? So when you start the therapy, it should be done for half an hour once a week for 6 weeks. And then if it's working very well for you, you go into a maintenance program. And so with a maintenance program, what we recommend is that you come in every 6 weeks for a 3-week block of 30-minute treatments. Does that make sense? That's all right. So when you start it, because you want to see if it's going to work for you, so we do an induction therapy. So the induction is introducing your body to the therapy to see if this is a good therapy for you. So the induction therapy is you come in once a week for half an hour and have the treatment, but you've got to come in for a total of 6 weeks for that induction. And then you assess whether or not it works for you. If it doesn't work for you, then you don't bother carrying on, and we can look at something else. But if it works for you, then you start a maintenance program of treatment. Does that make sense? Super. Yes?
Are there bad effects for other symptoms of Parkinson's if you do the Botox?
So with Botox, because it's placed directly into the bladder, it only affects the bladder. It's not like when you take medications, it goes through your whole body, so you'll have side effects in other parts of your body or other organs that you don't want treated. With the Botox, we put it directly into the bladder, so it only affects the bladder. So you don't get the symptoms like the anticholinergic medications do with the dry mouth or the constipation. It just affects the bladder. The only thing with the Botox is that for some patients, when you start out, if you put too much Botox in, you can paralyse the bladder completely, and then you have to use catheters. And so there is a bit of working out how much you need to put in to start with. Often, in saying that though, some patients do opt to have their bladders completely paralysed and start a process of what we call intermittent catheterisation, because it gives them the freedom of not having to look for a toilet because they can plan when they go to the toilet. And catheterisation is not as bad as it sounds, I promise. So sacral nerve modulation is the other type of neuromodulation. So this is just jargon for explaining what it is. It's slightly more invasive than the peripheral tibial nerve modulation system. This is, we put a lead into your back and a little place a little generator. So where are we? Over here. So this is the lead that goes into your sacrum. So this is your pelvis. These are your legs. This is your belly up here. And this is where the nerve roots. So that's the end of the spinal cord, and they come through here and feed into your bladder. The little lead goes in here through what we call S3 and goes down to the nerve roots, where the nerve roots are the ones that go off to the bladder. So we do this in 2 stages. So we put this little lead in first, and then we give you like a little cell phone and battery pack that you have to wear. And that we program to work out whether or not the lead is actually doing any benefit or giving you any benefit in terms of improving your symptoms. If the symptoms improve and you think, yeah, this is great, then you come back and we place this little generator into your top of your buttocks, so in your back. This is called neuromodulation. Interstim is the name of the company who produced it, or Meditronics with the Interstim. This little battery pack will last you about, I think, 10 years of the new batteries, and then when the battery expires, like all batteries do, you can just have another little battery replaced. So you can keep on rolling it over if it works for you. The thing with the Interstim is that it comes with like a cell phone basically, and it's programmed on it different types of generations to push, pulse generations to push through for you. So if one program doesn't work, you can try 2 or 3 different programs to see what suits you the best for your bladder, because everyone's bladder and urinary dysfunction is quite different. Again, similar to the peripheral tibial nerve, it does have decreased episodes of urgency, frequency, going to the toilet all night long, and additionally, this was designed for people who have fecal incontinence, so there's also decreased fecal incontinence with this as well. As I said, traditionally since the onset of Botox and these neuromodulation processes, these surgical interventions have really gone by the way. The bladder neck closure, augmentin and urinary diversion, which I'll explain what they mean in a minute, but traditionally we used to do these at least every 2nd week to every month in the hospital system. Now I would say we would be lucky to do them once or twice a year since the advent of Botox and neuromodulation. So hence, not many of us are trained in these anymore because we don't do them very often, but they are still a very good surgical procedure for people who've tried everything else and it's just not working for them. So a bladder neck closure and an augmentation. So this is your bladder here. I can't take credit for the drawing, that's for sure. This is, it looks like I've been drinking the way my arms are wobbling. These tubes here are your tubes from the kidney called the ureters, bladder, and then this is your urethra, so that's the tube that you urinate through. So when we close the bladder, we oversew it here, so you can no longer empty your bladder the way you were made. And we do this for people who are severely incontinent and we can't get control of their incontinence. So when we close it here, then you can either have a catheter that drains your bladder continuously out the top of your abdomen, or you can have a little tube made out of a piece of bowel that you put a catheter in and out of sort of every 4 hours during the day to empty your bladder and stop you from leaking. And augmentation. What happens with an augmentation? This is for people, again, who have so much urgency and frequency that they're peeing all the time or they're leaking urine all the time. We place a piece of bowel. We get a piece of bowel and we put it on the top to make the bladder much bigger. And the idea behind that is it can then hold more, so you don't have to go so often. It takes away some of the muscles that are contracting all the time in your bladder, so you don't get so much urgency, and you shouldn't have the related incontinence with it. And urinary diversion is when we bypass the bladder altogether because it's no good anymore, and we give you a bag that it sits on your belly to urinate through. But as I said, these are very much end stage when everything else has failed. So incontinence is the next topic, and how we manage incontinence. So with incontinence, there are four types of incontinence. As you can see here, there's urge, which is when you need to pee and you haven't got time to wait, and you leak trying to get to the toilet. Stress incontinence is the one that you see all the ads on TV for the light-bladed leakage. That's the coughing, sneezing, jumping, leaking incontinence. Overflow incontinence is actually when your bladder is so full because you're not emptying your bladder at all that it just starts to leak out because there's no more room for the urine in the bladder. And mixed incontinence is when you have a picture of all of them all together. With incontinence, the most important first step is actually to establish what type of incontinence you're experiencing. The reason for this is that the managements are quite different, and if you go down the path of treating the wrong type of incontinence, you'll probably end up worse rather than better. So with urge incontinence, the treatments are what we've just talked about, what we do for the overactivity of the bladder. So we start with conservative therapies, we try the medications, that doesn't work, Botox therapy, then the neuromodulations, which is the ankle acupuncture needle or the one in your spine, or the operations. Then there's stress incontinence. So stress is the cough, leak, jumping, leaking, going up the stairs, you start to leak. Anything where you're mobilising or lifting washing out of the washing machine, putting washing on the line and you leak urine, that's called stress incontinence. So the first intervention for stress incontinence should always be pelvic floor rehabilitation to try and get those pelvic floor muscles working better than they have been. Again, the benefit of doing this is there's no side effects of trying pelvic floor rehabilitation. If that fails you, the next step for this type of incontinence is actually a surgical operation. So there's no medications that help with this type of incontinence. So the type of operations that we have available for us are slings, sphincters, bulking agents, or again a diversion where we divert the urine into a bag. So these are slings, and they're all made of a proline type mesh. They are the mesh that was the same mesh that's been used that you may or may not have read about. It's caused a lot of problems in America where it's extruded and there's been a lot of litigious claims against it. These meshes are all female ones. The one thing I would say about the mesh for incontinence, it is not the same problem that they've had for the mesh that they're talking about in America. That was all mesh that was placed for ladies' prolapse surgeries. These are placed in a different position and they haven't had the same problems at all, and so there's no problem with these being used and being placed. And there's different types of slings for ladies. Men, there is a sling available for you as well. So we've got slings for everyone. Now a sling is placed under a general anaesthetic, and the idea with the sling is it places and holds that urethra up again and recreates a sphincter. So the sphincter is what stops you from wetting yourself, and that's what's weakened when you cough and leak. And so if we put the sling in, it's supposed to reproduce a sphincter and stop you so you can cough, move, and you shouldn't leak again. It's normally done as an overnight stay. You then are not allowed to do anything where you might lift or move things around for about 6 weeks while the sling knits itself into you and becomes part of your body. The success rate of these is about 80 to 85%. Yes. Mm-hmm. Yes, you can. Yeah, you can put sling upon sling upon sling if you need to. Yeah. Wouldn't recommend having them done repetitively very quickly, but yeah, if you need another one, because often with time the sling can move as your body changes, and so you can definitely have another one. Yeah. This is the artificial urinary sphincter. So this is also designed to stop stress incontinence, so coughing and leaking or moving and leaking. This is slightly more complex than a sling. This bit here, this goes around the urethra, so the pipe that we urinate through, and it squeezes it shut. What happens is when you need to go to the toilet, you have to push this pump. So for gentlemen, that's put down in your scrotum, so it feels like you've got a third testicle. And then that squeezes the water out. You can go for a pee, and then the fluid goes back into this bit here, which we call the cuff, without you having to do anything else. The difference between the two is with the slings, you can just pee like you would normally. You don't have to push anything. With the sphincter, you have to push this, so you have to remember to push it, otherwise you'll end up in a situation where you can't pee because it does such a good job of holding onto urine. You're not going to leak through that puppy, that's for sure. This was initially designed for men, and so most of the research and knowledge about it is in males. However, in saying that, females can still have this should they need it. It's just a little bit trickier to place, and I think there's only 2 of us in New Zealand that have placed them on females for that reason. And when they work, these things are very good. They work really well. The problems that you can have with them are similar to slings. If they get infected, they have to be removed. So patients who have mixed incontinence, so that's a bit of everything. So you cough and you leak, but you also have the urgency that makes you leak as well. So the most important thing, if you've got mixed incontinence, is to work out what bothers you the most, because that's the first treatment line that should be chased. Because if you treat the symptom that's not bothering you quite as much, you may end up in a situation where you're worse off than you were when you first started to see the doctor. So that takes a little bit of a conversation between you and your family doctor or you and your urologist to work out what worries you about your incontinence the most, which symptom is the most bothersome for you. Often with mixed incontinence, because it is mixed, you'll need a mixture of treatments, and there's often a little trial and error that needs to go into working out what works best for you, what is the best result for you, and how to get you dry. Overflow incontinence. Overflow incontinence is when your bladder just isn't working anymore. It doesn't pump the urine out like it's meant to pump the urine out, and so it gets so full that you're just dribbling all the time. Or if you roll over in bed, you start dribbling. So there's a couple of ways that we manage overflow incontinence. And so what we want to do is obviously decrease the leakage, so then you can get out and do things. So often with overflow incontinence, you again have to have a combination of treatments. Traditionally, we used to use alpha blockers, which is a medication that opens up the bladder neck. It's only used in males. It's no good for females because you don't have a prostate or a bladder neck that has these effects. So if you get, as a female, if you get given an alpha blocker, you might need to remind the doctor that you don't have a prostate. So the idea behind, you want to open up the bladder neck so that you can empty your bladder, but often people who are in this situation, even just opening them up, that bladder no longer contracts, so it can't pump the urine out. So that's when you have to look at catheter uses. These are some fairly prehistoric-looking catheters, I'm afraid, but these are ones that go in and stay in. But the catheters that we often recommend, if you've still got good hand-eye coordination, are intermittent catheters that you can put in and out, and you can throw them away or use them a couple of times, and they are not as bad or as horrible as the ones that go in and stay in that most people experience when they go to hospital for some other reason. So the last set of symptoms that I was going to go over the management for today is the decreased flow or the inability to urinate at all. So this symptom, like all the other symptoms, needs to have a good investigation to make sure that it's your Parkinson's disease that's making this occur and it's not other symptoms or disease processes that occur with age that are kicking in. This can actually occur in both male and females. People talk about it more in males because you hear about prostates getting big and men can't pee anymore, and as you can see, there's always the dribbling on your toes jokes. But in Parkinson's disease, both male and females are affected by this equally. So the reason it occurs in Parkinson's disease is that, like we were talking about before, the bladder no longer contracts. It's just given up the game. Instead of working as a pump, because normally it pushes your urine out, it just doesn't do that anymore. So you end up not having a good flow, because if the pump's not working, the pipe can't be filled till empty. The other thing that can happen is the sphincter. So your sphincter sits at your bladder neck and is the thing that you relax when you go to the toilet. I'll just find that picture of the bladder. So this is what we call the bladder neck, and this is where your sphincter sits. So the sphincter is a muscle, and it needs to relax for you to go to the toilet and empty your bladder. If the sphincter doesn't relax, as it can do in Parkinson's because it can have bradykinesia, so slowness of movement, you will not empty your bladder properly and you'll have a slow flow. So and also you can have a combination of a bladder that doesn't contract and a sphincter that doesn't want to relax. So you can have all of it, unfortunately, at the same time. So what can we do with this? Well, conservative therapies involve catheters, particularly if the bladder's not relaxing. If the bladder's not contracting, because unfortunately there is no medication currently available to make a bladder contract. So we often look at catheters. So catheters can be either long-term or intermittent. So the long-term catheters are the ones that can go in, either through the urethra or through what we call the suprapubic tract, which is a little tract just above the pubic bone, and they work to siphon the urine off and drain the urine continuously for you. And you have a bag that you can put either on your leg, up a thigh or calf, and then a big bag for at night time. Or you can look at an intermittent catheterisation. So intermittent catheterisation is when you will place a catheter in to drain your bladder by the clock, so every 4 hours, drain your bladder off, take the catheter out, so then you don't have to travel around with a catheter or the catheter bag. Outside of the conservative therapies, we then look at alpha blockers. So as I said, these are for male patients only because they only act in the area where the prostate is attached to the urethra. The idea behind this is it opens it all up around the bladder neck and allows an improvement of the flow. It doesn't help the bladder contract, so if your bladder's not contracting, this medication is not going to help you. The problem with alpha blockers is it can worsen falls. So if you have autonomic dysfunction that's causing your urinary dysfunction, chances are you already have what we call postural hypotension related to that autonomic dysfunction. So that is a symptom that when you go from sitting or lying to standing, your blood pressure doesn't keep up with you, so you feel faint. So if we add this in and you already have that symptom of feeling faint and we add an alpha blocker, and your risk of falling and hurting yourself does increase with it. So it's something to be very aware of, because obviously having a fall and hurting yourself is not a good outcome for any management of any urinary problem. Traditionally, for gentlemen only, we used to resect out the prostate to try and remove all the prostate that may be decreasing your flow. So classically, we avoided this altogether because we thought that the rates of incontinence after this procedure for Parkinson's disease patients was up to 20%. However, more recent research has shown it's not as high as 20%. It's around 8%, which is still higher than the 2% rate of incontinence after this procedure for someone who doesn't have Parkinson's. So it is an operation that is available, but you have to be aware that the rate of incontinence afterwards can be up to 8%. And the reason for that often is because not only are you blocked and your sphincter's not opening for you, but you may have detrusor overactivity, like we talked about before, where you have urgency and your bladder's contracting and making you go to the toilet, and the only thing that was stopping you from wetting yourself was your prostate. So if you remove that and you've still got a bladder that's contracting all the time and you no longer have a prostate blocking it, you may end up being more incontinent or having incontinence you may not have had before. So with that in mind, it's very important if you have been nominated to have a resection of your prostate as a gentleman when you've got Parkinson's disease, that you have all the appropriate investigations prior to it to make sure you can close your sphincter, and this means that you need to have urodynamic studies done. So mixed symptoms. So a lot of people don't come classically to the clinic with just a bladder that works too often, or they can't pee, or they're just incontinent. They often have all the symptoms all at once. And so with that in mind, the most important thing to undertake is a proper gather of all the information before you undertake any management. And so often it sounds like we're sort of dragging things out for you, but what we really want to do is work out what is the most bothersome symptom, what is the symptom that we can fix first and foremost, and then let's go back and look at how well we've done or haven't done and work out where we can go to next to make things better for you. The reason for that is if we throw a lot of things at you at once, we won't know what's actually worked and what hasn't worked. And so it's important to do it in a stepwise, very methodical fashion to try and improve the symptoms, to therefore improve the quality of life. And as I said, a lot of my patients, it's a bit of a give and take and a bit of an art rather than a science at that point when it comes to managing the symptoms related to Parkinson's disease with your plumbing. More questions? Yes.
If someone goes to their GP and says, I'm having problems with my plumbing,
Yeah.
and the GP
So initially, I think it's really important to advocate for yourself, because there is unfortunately a lot of people out there who still will tell their patients that it's all related to age. This is the way it has to be from now on. Depending on the symptom that you present with is depending on how the GP can take it from there, family doctor can take it from there. Say if you have a little bit of overactivity of bladder, they may want to trial you on some conservative therapies or maybe start a medication and see how that goes. If that fails you or you're not happy with the outcome of that, then they should refer you on to a urologist. Same if you can't pee and they put a catheter in and they say that's it for you, you can say, well, actually, I want another opinion, send me through to a urologist. We in New Zealand have not been very good in terms of providing a neuro-urological service, and so there will be a lot of family doctors out there, unfortunately, who don't realise that you do need to be seen by a urologist. To give you an idea, I am the only trained neuro-urologist in the entirety of New Zealand, and I have only just started clinics which are predominantly neuro-urology, which the DHBs are not that interested in because it doesn't result in a lot of surgery, so there's not a lot of funding for it. Henceforth, there's a lot of people out there in the community who suffer considerably with the lower urinary tract dysfunction related to neurology, who don't realise they can get help because their GPs don't realise that there is now a service and there is a need, and therefore you need to advocate for yourself and that, unfortunately, and push your GP to push you through.
Is there much funding available for that?
There is funding for all the operations, all the medications. There's funding for Botox, which there isn't in a lot of countries. The only thing that we haven't got funding for is this neuromodulation, which is the peripheral tibial nerve modulation or the sacral nerve modulation. But in saying that, though, I have a business plan that I'm putting forward to the DHB, so all going well, we may get some funding. It won't be a lot, but if we start with a little bit, then hopefully we'll get more.
How long is the waiting list to see an urologist?
How long does it take to see a urologist?
Is it a waiting list or not?
So in the public health system, when your GP sends a letter through, everyone gets triaged to their level of urgency. In the last year, the government has now given us waitlist targets, so everyone has to be seen within 3 months from the letter for their first consultation. If it's deemed that you need a surgical procedure, you have to have that done within 4 months. So it's not as bad as it was, 5 years ago. It's still not, unfortunately, urgent.
Regime, given cognitive decline is one symptom, which I would expect isn't reversible. Constipation is another side effect, which if that is already a problem,
Yeah.
exacerbated.
So you mean like taking the medications, the anticholinergics? If someone's already got cognitive decline and you don't want to make it worse, or they're already quite severely constipated, then you don't have to. There is an option to saying, well, actually, this isn't a realistic approach for me. I need to go across to this approach. And that's where having a very honest conversation and seeing someone who's has good knowledge in it is really helpful, because everyone's different. Everyone's Parkinson's disease progresses differently. Everyone has different symptoms. And so these are just general guidelines. But yeah, if someone's already quite severely constipated or they're having problems with their memory and remembering to do things, then I would probably bypass a lot of those medications and go to neuromodulation if it was available, or Botox.
Do you think tricyclics are helpful for the treatment of some of these problems?
No, not anymore, no. In the late 80s, we used tricyclics a lot, but the latest research is that they don't really help. They're very good for painful situations, if someone's got painful urinating, and a small dose for neuromodulation, but in terms of emptying the bladder or controlling overactivity, the research is not robust and it hasn't been proven. Sorry, say that again.
I'm asking about.
Okay.
Well, from my own experience, what I'm talking about is organism, perhaps like a small mouse or a small cricket or something like that, that makes its home in the genital sort of area.
So two competing organisms, you mean, in the bladder that's causing problems?
Probably more in the rectum than the bladder, I would think.
Okay. So generally speaking, if someone's got urinary dysfunction or problems with their bladder that's causing all of these bits and pieces to occur for them, one of the first things that should always be investigated is to make sure that your bladder is free of bacteria or fungus. That's the other thing you can get if you're not emptying properly. You will always have problems with your urinary tract or your plumbing if you've got bacteria or fungus in there at all times. And so that would be the very first thing your family doctor can always rule out for you, is to take a urine sample and make sure. Because it's simple to treat. Some antibiotics, and then you're improved. No, really? So the question is, what happens to people on the shore and Waitakere Way? So for the shore, they don't have a established Neuro-Urology service. For people who are very much end stage, there is a policy of referring them through to see myself at Auckland. However, they are, if someone fails anticholinergics and they need Botox, they will do Botox in the system over there. They don't do neuromodulation, again, because we still haven't convinced the DHBs it needs to be paid for. And they would probably get you to come across and see me before they offered you a diversion or something like other major operations, and saying that they're more than capable of performing the operations at the shore.
What's your opinion on Ovestin hormone cream?
So Ovestin hormone cream is very good for overactivity of the bladder in a non-neurological setting. So someone who has overactivity of the bladder who does not have a neurological cause of their symptoms, so someone who doesn't have Parkinson's disease or multiple sclerosis or any of those, it has been proven to be very effective to decrease urgency and frequency. But in the neurological setting, because it actually relates to the nerves not communicating properly anymore, it's not as effective.
You are the only one here who does the Euro. I'm just curious to know where you did that part of your training.
So after I left New Zealand, I went to California and worked with a gentleman called Professor Anthony Stone, who is one of the gentlemen who invented urodynamics back in the 70s, and is a well-renowned, well-respected neuro-urologist and they call it functional voiding now, specialist.
Sometimes when I'm working downstairs, I find an urgency to go, and I think, oh, I've just got to do this because I can't stop something. And then half an hour later, I realised I haven't been to the toilet and I'd forgotten all about it. Is this something mental?
So what that is that's when we call those distraction techniques, and that's also part of pelvic floor rehabilitation, because sometimes when we have urge and we get into the habit of rushing to the toilet because we're worried about leaking, we can then be a self-fulfilling prophecy where we untrain our bladders to hold. And so if you get that urge and you're able to defer it, then your pelvic floor is working well and things are fine. Thank you, everybody.